DSRIP is an ambitious effort. 25 what we call performing provider systems, or these large groupings ranging from either a couple of hundred on the small end up to thousands of organizations and providers coming together. So it's a huge effort, and we're in the midst here of beginning move towards the first payments rolling out the door. So we're very excited about that. But it's a very challenging effort, and for each of the performing provider systems, and Pam knows full well, Maimonides playing a key role as a lead for one of those 25, how challenging it is to try to build and then maintain these large coalitions, and lots and lots of stakeholders. Everyone has town hall meetings and filling up large venues full of interested parties who want to be actively involved in this initiative. So while it's exciting, it still is a huge, huge effort, and it's going to be a major focus of ours throughout the next 5 years. But I think also that the other big thing that's coming this year, and what we're working on very hard back at the health department, is the move to value-based payment. And that's, I think, to me, as important as DSRIP is, and really DSRIP to a great extent is about trying to basically transform the delivery system, improve outcomes, ensure sustainability for safety net providers, but it's also, in order for us to make that sustainable, that investment, which is a one-time federal investment, sustainable, we must change the way we pay for healthcare. And what I mean by that is we need to start reimbursing providers when they collectively are successful. The problem with today's majority of how healthcare is paid for today is that the more you do, the more you get paid. Whether or not the patient got better, whether or not there were good outcomes, whether the service was effective or not, really very little of our total payment in healthcare is actually tied to performance, and we need to change that. And I think what that'll also do is it helps give us an opportunity that as we are successful at better managing patients, at better addressing the social determinants of health, and as that generates savings within the delivery system, that savings can in fact be captured. Because part of the problem now, and reason why safety net providers are so financially struggling, is because even when they do the right thing, it goes against their economic interests. And I think we have to fundamentally change that. And I think that that's a huge effort. Our goal is somewhere between 80 and 90% of all of our Medicaid payments by the end of the 5 years of the waiver period, so by the end of the decade, will be in value-based arrangements. And that is no small task for a program that spends about $59 billion a year. Yes. So that's, and while a lot of folks are focused on DSRIP, the value-based payment train, which is leaving the station, it's a requirement of the waiver, is moving, and that is obviously going to be a big focus of the year as well.
And we'll dig into a lot of those details momentarily, but first, Pam, I'll kick it over to you. What are the pros and cons of this, and what have you had to deal with? What are the challenges specifically early on with DSRIP and value-based payments?
So I think this is on, right? I think I at least have, I'm older than most of the people in the room, I think, and I remember in the 60s and 70s, doctors writing prescriptions for their patients for eggs and milk, prescient, very. And it's always stayed with me that it is not, that hospital-based medical care is simply not the be and end all of the people's health. This definitely made me an outcast among my fellow CEOs. But of course, we do believe that, and we've been working on recidivism for congestive heart failure patients for a long time. And so we have been very fortunate, and the state, between the state and the federal government, we've had a lot of help in trying to create different models of keeping people out of the hospital. And Jason actually, or let's say the taxpayers of the state of New York, are actually benefiting from the work that we've done, because we have, when we put groups together, reduced inpatient admissions significantly, except at the moment there is no risk sharing, and so over the last year or so, while we've been working very hard with a growing number of community-based social service and wraparound organizations, and our admissions have gone down, of course, our reimbursement has gone down. And so from my perspective, even though it is scary and the idea of value-based purchasing is definitely a revolution, I mean, it can't happen fast enough for us because we don't want to be at the very end of being successful and having the money go either to the state or to insurance companies. So we're very committed to the idea that it takes a village and that you have to work with providers who, for many years, hospitals were disdainful of. I mean, I've worked in and out of the mental health field for a long time, and I will tell you that if you get together a room full of community-based organizations that do mental health and ask them what their immediate reaction is to the word hospital, they decompensate completely because, and we heard this in the Medicaid reform team task force, hospitals are glommy, they steal our patients, they're unfriendly, they're scary, they're not part of the solution. And, you know, to some extent, there's a grain of truth there. And so we have to, in DISRIP, rely on people who see patients from a different perspective, who aren't providing medical care necessarily. Maybe they're doing drug treatment is medical care, housing, or job training. We work with the discharge program at Rikers, and if ever there was a group that needed care management, it's people who have touched the criminal justice system. I mean, it's at least, I am happy about the fact that it's sort of out in the open, although I think the solutions are still jelly. And I certainly give our mayor a lot of credit for that. But we have to work with these people who see our patients from a different perspective. And actually, as I'm sure Ram knows, you can't run a public hospital without reaching out and building constituencies, you know, with every single community-based organization around you, because their clients really should be our patients. So I will say managing DISRIP is an undertaking, and you've got to be very smart, tenacious, definitely have your virtual Valium with you at all times. We have a very sort of a democratic, if you will, governing model that puts smaller institutions at the table so we can make sure to hear their voice. But, you know, the jury, of course, is out since the work has just begun. So you'll have to invite Jason back, and I'm always glad to tell you what works and what doesn't work. But I am excited, and I think that the health department has finally succeeded in doing something that people, including my very smart predecessor at Maimonides, Stan Bresnoff, has been saying since I was a healthcare analyst at HHC. There has to be a link between what makes health sense and what makes fiscal sense. And I really think that the health department and Jason's leadership and a governor who has promoted this and a mayor who certainly has believed in this, and the mayor before our current mayor, who really was a healthcare mayor, really believed in public health. And I think we're on the road, so.
And Linda, obviously you have a wealth of experience having served in the Bloomberg administration for so many years, and I believe you were on the Medicaid redesign team task force as well. But from a sort of outside perspective now, what's your take on what's going on at the state level, and what do you see going forward?
Thank you. And I feel like everything that I was hoping to say has already been said, so now I get to go on to the details. But first, I want to say how thrilled I am to be sitting between these two individuals. When we heard about this guy named Jason something coming from one of those states, Wisconsin or Milwaukee or whatever, like it's over there. It's like, what does he know about New York? Yeah, maybe he did a good job over there, but he'll never make it here. And I have to say, he deserves the Medicaid redesign process as a finalist in the Harvard Kennedy School Innovations in Government Award, and it deserves to get the highest prize because it was really a remarkable process that helped to move an incredibly, incredibly difficult situation along to, I think, something that holds great promise, and that's a great deal due to Jason's leadership. So yeah, so everybody's fingers crossed because it reflects on all of us. And then I don't know how Pam runs such a phenomenal hospital system because she spends 100% of her time helping us. Obviously a huge figure in the Medicaid redesign process, but particularly for women in leadership positions, she never says no to any request for any kind of personal guidance, advice, and mentoring. So not only is she helping you all run your hospital system, she's helping us individually with our own lives. And so bless you, yeah. So I thank you so much for the last question that you gave to Dr. Raju, because that's what I wanted to talk about, which is the racial disparities, the income disparities in health outcomes. A great report was just put out by the Department of Health and Mental Hygiene's, their biannual vital statistics report. Good news and bad news. If you just look at one key indicator, which is premature deaths, so that's deaths before 65 by race. Well, if you look overall, great decreases in premature deaths, and that's contributing to the increase in longevity in the city. If you look at it by race, there's been a 33% reduction in the disparity gap between African American and whites, and about the same amount, a little less for Latinos who are already closer to whites. So the great news is that racial disparities and premature deaths as a leading cause of, a leading contributor to longevity is decreasing. The other side of that coin is that there is still about a 6-year gap. So if you look at a African American child born today, and you will need to say to that child, you have about 90% of a life compared to a white child born today. You're likely to die, your life expectancy is 90% that of a white child. And then if you want to turn that into political terms, think about what that means for the voting age population. Because that means probably, I don't know, somebody who is better at math can do it, but let's just say that's 20% fewer voting age people compared to, so of all those children born today, less representation among voters. And so this translates into the priorities that are set, the values that are expressed, the structure of our systems that are taking care of all of the citizens of the city. So reducing the racial disparities in health outcomes, clearly aligned, geographically clearly aligned around income disparities is a huge social justice issue. So I guess how this all relates back to healthcare is that if we can use those social networks to produce better collective outcomes at the community level, we can see improvements. And I really do believe that this is achievable based on over a decade seeing that closing of that gap by 33%. But it's really hard. So I think what Jason has done is he's handed the city collectively an opportunity. And because we are one of the few demonstration projects going on nationally, and it is really hard to make this stuff happen, so there will not be many of them, and so a lot is riding on what we do in New York. I think it really is incumbent on us collectively to figure out how to not screw it up and to make the most out of it. To do that, and this is, I've never myself, except if you count supervising health in hospitals, which I don't, as healthcare experience. So, and thank, Alavilis before Dr. Raju, but, phenomenal leadership. So I did what I could to help them along, but, they were the experts that were running the system on a day-to-day basis. If you think about the way that the power structures are still related within this whole managed care, DSRIP. The good thing about being an outsider is that you forget all the acronyms, and when they don't come back fast, you're kind of happy, right? So all the stuff that's going on, the one challenge about it that it does remain very hospital-centric in terms of where the power sits, where the decisions are made, and where the money flows. And so it is up to the leadership of the hospital systems to open their doors and to share that decision-making and to bring those community partners in. Collaboration is really hard. It takes up a lot of time. You have to deal with people who don't disagree with you. You have to deal with people who don't agree with you, who don't kiss up to you every day, who you don't pay their salaries, so they're not as invested in making you look good. And so you have to figure out a way to have the leadership of hospitals be really invested in putting up with the work that goes on with that. And being willing to do that and understanding that it is in there, and Dr. Raju said it at his opening, it is in the hospital's bottom line interest, but I think we have to put the patient interest above the bottom line interest. They can work together, but I would like to hear these conversations be much more about what are we going to do to improve the outcomes in our communities, how are we going to get the data into our hands, into our community hands, in order to have it and share it, and how are we going to ensure that those collaborations are strong collaborations that push the real human needs of the clients, of the citizens of the neighborhoods onto the forefront of the discussion, so that we can really get at what are the ways that these dollars should be spent in order to change those outcomes. I think if I had a couple of concerns about just on more of the technical level beyond sort of the urgency level is a concern about data sharing. I think electronic records and systems that can really effectively share data, particularly when you're talking about sharing medical and social need data. There are still ineffective tools for solving that, and we need to make them more effective, and we need to be more open. We need to find more creative solutions around data sharing. We probably need to put a lot more money into technology so that people have those resources in an effective way to get the information flowing. And I would say that I'm probably concerned that the resources that are available for these alternative approaches that need to be integrated are not yet sufficient. And I am far enough away from it that I used to have like a constant vigilance on where every new penny was going to jump up, so I could figure out how to grab it. And so I'm not as vigilant anymore. But that's what I would say. We really need to think about how some of these savings that will get produced can be pushed into some of these alternatives. The last thing I would say is that it's. I understand people feel under incredible pressure at how the rapid pace of change, and I appreciate that, and I believe it's true, and I believe it's not going fast enough, and it's particularly not going fast enough for children.
Any that you want to respond to? No. Okay. Well, building on the issue of disparities, I mean, a couple of concerns I've read about maybe safety net hospitals, that they won't be able to have as much control over outcomes for a lot of lower income patients. I'm also curious about, rural or smaller entities that might feel pressure to consolidate or won't be able to have the resources to fulfill all these requirements. How are you going to address both of those issues going forward with a value-based and district process?
Sure. So as the payment systems change and as the district continues to roll forward, inherently in that is that the delivery system is going to change. And I think the delivery system has no choice but to change, because I don't think that the current delivery system as it's currently configured and the sets of services are, one, what the population of the state of New York needs, meaning that we have an unbalanced system. We rely too heavily on institutional level care, and there's lots of measures that can show that, whether that's avoidable hospital use or people in nursing homes who really shouldn't be there based on their level of need. And we have too little in terms of the community-based services. Well, that's not only primary care, which people talk a lot about, but it's also community-based behavioral health, which we tend to underinvest in. We have more psychiatric hospitals than any other state times 2. In New York, but yet at the same time, we don't have enough community-based behavioral health providers to meet the needs. And I always say, particularly on the behavioral health side, we have a significant challenge and a challenge we must address. In the Medicaid program, more than 70% of readmissions that occur on an annual basis are for people with a primary diagnosis in behavioral health, either significant persistent mental illness, substance abuse, or in many cases, both. And unless we're willing to address that issue, we're going to have challenges. So that means we got to rebalance the delivery system. We need to begin to shift away from institutional care, and then we need to do that, move more into the community. But that said, DSRIP will help, and each of these performing provider systems is required to basically develop a plan and then implement that plan about how they're going to rebalance their services and ensure that we have continuity of care throughout. But that's no small task. It's going to require not only DSRIP funds, but the capital funds that are in the governor's budget, plus what other funds can be leveraged for investments. And it's going to be a bumpy ride. There's no question about that. I think what it's going to mean is there's going to be consolidation. And there's going to have to be closure of certain services. And those services are going to have to be replaced with other services that better meet the needs of the community. That transition will occur in every part of the state, in urban, suburban, and rural. We have actually right now more challenged safety net providers in rural New York than we actually even do in terms of raw numbers in urban. So this is a challenge that's facing the entire state, but I think we have no choice. We have to rebalance the delivery system one way or the other. The waiver and the capital funds, $2.2 billion in funds, is an opportunity, but collectively, I think that's going to be one of our core challenges. How do we ensure a successful transition to the delivery system that matches our needs? How do we help safety net providers through that transition? And I think that's going to be one of our great challenges over the next 5 to 10 years.
I have to say that if you look at Brooklyn, and this is not to denigrate the really devoted hospitals that are serving low-income and indigent patients, but if you look, there's a lot of hospitals in Brooklyn competing, none of them with enough resources, competing for patients, for God's sake, and for all the money that is spent, guess what? The health status of the communities that are being served is wholly inadequate. That's an understatement, but I want to be polite while I'm sitting here. I mean, it's a disgrace. So something is wrong here, something is really wrong here. And I think particularly in terms of the mentally ill, which I know Linda, when she was deputy mayor, spent a lot of time and energy on, and I think we all have. I mean, it's not just that people's mental illnesses that puts them in the hospital a lot. It is the reaction of drugs they take on their metabolic systems, all sorts of things. I mean, remind me not to be poor and mentally ill in the United States. It's terrifying, really terrifying. And it's got to be the single biggest cost to New York State, to the Medicaid program. And the only way we're going to manage it is actually by managing those patients and really focusing on them and following them. Actually, there is at least one great web-based system, and that HHC now has adopted. So we in Brooklyn are working with 5 other hospitals and with HHC. And with respect to HHC, I mean, their patients go to HHC hospitals and ours go to our hospitals, but they don't stay only in one box, those intrepid patients, you see. They do go where they want to go. And really, in the end, who cares if the health status of this community improves measurably. And if the quality of care improves, which HHC is working on, I think we're all working on it, and that the costs become more efficient so that some of it can be reinvested in healthcare or in the other things that go up, that go to making people healthy. It's an enormous challenge, but it's got to happen. It's really got to happen. And we hopefully will be modeling it in small places across the state of New York. Certainly in Brooklyn, that's our reasonably ambitious goal. And hopefully the success will be measured in terms of replicability and how quickly our nation really moves to trying to deliver health care in a different way.
So I would say on this issue of the mentally ill, the sort of excessive numbers of bed by comparison on the psychiatric side, and extraordinary health costs, that all of that, changing all of that, improving all of that is highly dependent on improving housing resources for individuals. And I think we eked a little bit of money out of the waiver for some housing. Is that true? No? All right. So this is, all right, so this is an issue. For some reason, I thought we had a tiny bit that was allowed. All right, so now we're really in trouble. Because the other place, of course, where the mentally ill go is they go into shelters and they go into prisons and jails. And as you know, neither shelters nor prison and jail systems can be expected to be the mental health delivery system, although they are, and they are often judged on that. It's highly inadequate, and it's extraordinarily stupid as a way to spend money. And so I think the solutions around stabilizing these very high-cost population, which are a small percentage of the people and a large percentage of the cost, is that we got to get them stably housed. And so I would say two things are needed. We just have to invest in more supportive housing for people who have no other family to live with. And we have to invest in family-based support services so that family members that continue to support their mentally ill loved ones at great social cost to their households need help and support in doing that. And if we don't have that, and if we don't make that part of our solution on a community level, we're just going to keep churning the same problem.
Would you mind if I won't.
Just to move forward, and one thing you mentioned earlier, the question of risk, and as you're building out all these collaborations between providers and insurance companies and different community centers, I think one question has been sharing risk. It seems clear that everyone's happy to share with the savings, incentives, get grants, get money. How do we envision this going forward in terms of who shares the risk, and is that really up to the different collaborations to figure that out, or is there a vision from the state?
Sure. So sharing risk and sharing reward, two sides of the same coin, is I think part and parcel of the move to value-based payment. It's also part and parcel of DSRIP, which is a performance-based program. And CMS was very clear. These payments that are going to providers, they're only allowable under federal law because they're performance-based. You have to achieve specific milestones, and when you do so, then you qualify for the payment. So the first payment PPSs receive is the fact that their application was approved. But from that point forward, everything else is going to be specifically tied to performance metrics. They start out sort of as process things, meaning they're implementing the projects as they committed to in their application. But particularly by year 3 and on even more in 4 and 5 of the waiver period, you have to perform. You have to literally improve Medicaid patient outcomes in order to receive these payments. So providers are now moving into risk arrangements, whether they like it or not. And our hope is that what DSRIP does is it allows them to invest in the strategies, the partnerships, the relationships that are necessary for them to be successful in those types of arrangements. We have providers across the state, including right here in New York City, who have made those investments in the past and are successful as a result of that. One right here with Pam with the Maimonides, have shown that when you make and you implement initiatives designed to better manage population health, you can generate savings. You can improve patient outcomes. So it can be done in all kinds of different settings. But I think move to value-based payment is then the next step. Then you're really starting to say, okay, my base reimbursement in the Medicaid program is now going to start to flow to me in different ways. For us, the first step towards that is what we call upside-only risk arrangements, where you go into a contract, continue to be paid, you have revenue coming in that's still fee-for-service, but at the end of the year, you look and see, did the population health improve? And was there savings from total cost of care standpoint? And then if so, then you get to capture a portion of that savings. So there's a reward to you at the end. The downside of upside-only risk arrangements are that you don't get to keep all the savings. Maybe you get to keep about half the savings. That means half of the savings generated from your collective efforts is going back to the insurance company, potentially going back to the state Medicaid program. So what we would want to do is, as people are successful in that first arrangement, is to go to the next, where you take on upside and downside risk type of arrangements. In those arrangements, then you get to capture, say, 90% of the total savings that you generate. Now, you have the risk associated with if you don't perform, so we don't want people to get there too quickly. But I suspect that once people begin to make the investments in the strategies, they begin to change how they're behaving and the way they're treating patients and the way they're addressing population health, that they will want to get from level 1 to level 2 pretty quickly, because they won't want to see savings generated by their efforts going out of their institutions, out of their provider groupings. And so, but I think where the ultimate exciting, and this gets to Linda's important point about housing, which I completely agree with, which is when you get to what we call level 3, which is now you're receiving a bundled payment or subcapitation, a payment that's coming to you that isn't linked at all to the utilization of services. It's linked to how am I meeting the collective needs of this patient. You're now giving yourselves a lot more flexibility than the traditional reimbursement systems allow. Now you can have someone who's a very high-cost Medicaid member living in your community. You could say, perhaps providing them with a housing subsidy, right? Or putting an air conditioner into their apartment, or other types of investments are more cost-effective than having them in the emergency room or in an inpatient setting, 10, 15 times in a given year. And I think that's the ultimate place where we want to get to. It won't take us years for everyone to be able to get there, but some already are. And I think, the example, and Pam could probably tell some stories about her, but I know in the case of Montefiore, who's been leading edge of this for quite a long time, they are in these types of more advanced risk arrangements, and literally for COPD patients that they serve, they literally every year go in and install air conditioning units. Because it's very difficult for someone with COPD to be able to treat their illness in the midst of very high temperatures with very poor air quality. And it's one of those things the traditional reimbursement system wouldn't pay for. But when you get to that more advanced reimbursement system where you're receiving these flexible bundled dollars, now all of a sudden it opens up a whole new set of strategies that we think are going to be much more cost effective in the long run for really improving the health. And then hence also, we think helping to ensure these providers are sustainable long into the future.
So I do want to, and you and I talked about this on the phone, I do want to sort of speak briefly about redefining the idea of risk or broadening the idea of risk to include people who are currently working in hospitals. Now, it all sounds great, and it is great, but of course, we've been doing this for almost 10 years now, trying to do a better job of managing patients who suffer from chronic mental illness. But you see, the elephant at the table is the issue of jobs. And what jobs in the new healthcare paradigm are going to look like. And as we sit here, thanks in part to the federal government two-midnight rule and to our own work in managing care, you see beds are closing. They're closing all over the city. Often there's a big crisis and to-do when a hospital closes. But you see, the hospital bed, the number of hospital beds, certainly in this city, is shrinking like right while we're sitting here. And what are we doing about jobs? And thinking about what is the role of a respiratory therapist outside the hospital? Who's the employer? I mean, we have to grapple with this. And I do give Greater New York a lot of credit for creating a forum, which they have done, with certainly 1199 participating. I mean, I would like to see a table where District Council 37 and 1199 are sitting. These are problems that aren't really unique to the public or private sector. I mean, for our work, 1199 trained 400 care managers, not in hospitals. You know, we're not good at that. They trained them in the community-based organizations, and to their great credit, even trained them in community-based organizations that aren't unionized. But everybody can't be a care manager, you know, that gets paid. So we really have to challenge ourselves, and DISRIP does have money for some of this. But you have to view this as being a risky proposition for people whose careers and whose livelihood depend on these hospital structures that they work in.
It's a tremendous resource to leverage.
Huge. Yes, yes, it is. Yes, it is.
That's a fascinating point. Just one more point I wanted to touch on, and if we have time, we'll take some questions from the audience. The question of value. Obviously, the traditional fee-for-service system, it has the advantage of being simple. Well, measure
If anything in American healthcare is simple, but
relatively
well known.
well known. Right, understood. So,
Yeah.
you know, if you're doing value-based payment, you have to determine what is value, and that can be very subjective. And so I'm wondering, how will that be determined, and how do you make that uniform if everyone, you know, maybe is coming up with their own definitions, and you have a hospital that has like a bunch of different insurance companies they have to deal with, and everyone has their own way of doing it? How are we going to arrive at a uniform system, or should there be a uniform?
Well, you raise a very good point. And it's a challenge that we have a group of about 50 stakeholders that are working with us on the development of what we call the roadmap to value-based payment in Medicaid. And one of the most challenging sort of trade-offs that we're grappling with is uniformity versus flexibility. Now, the argument in favor of uniformity is that if you're a clinic that has a contract with 6 or 7 insurance companies, uniformity, having one system that you can use and then negotiate off of a reimbursement is an attractive undertaking. It makes life certainly easier for you. If you're maybe a little bit more sophisticated provider, you might like to have more flexibility, less uniformity, because that allows you to maybe tailor agreements to what your unique needs are. The other benefit of tailoring is not every community is the same in terms of their healthcare assets, their challenges. You know, we want to avoid the one-size-fits-all idea around value-based payment. So it's a thing that we've been grappling with, which is how much uniformity versus how much flexibility we're trying to set the right balance between those two very reasonable perspectives. But I think at the end of the day, and in certain settings, we're going to end up with more uniformity. I know, for instance, the federally qualified health centers, as a group, are in the midst of trying to develop their own approach to value-based payment because they have a unique federally required reimbursement system. And they have a strong interest in wanting to have some standardized system that would apply to all of them. But I think in other cases, in other types of care, we're going to allow more flexibility. Basically, what we've been suggesting, and the document, the roadmap is out on our website, is we're suggesting a menu of choices that people can choose from. So there is some structure in this. We draw, you know, a box around it. But that said, if providers and plans mutually agree that they want to go out beyond that, and it's consistent with our goals, we also allow some off-menu type of agreements. We don't want to be so stifling as to stifle innovation. The idea here is we're setting a path for 5 to 10 years, and sometimes the problem with government policy is it gets set and it doesn't evolve, so we want to avoid that pitfall. But it is, I think, a challenge as we move forward, which is how do we balance those two competing reasonable positions.
Okay, great. I think we have time for maybe 1 or 2 questions. And if you could, just one question, and Jasmine will bring a mic over to our one selected questioner.
Thanks. My name is Caroline Lewis. I'm with Cranes, and I have a question for Mr. Helgerson. So when are the DSRIP valuations going to come out, and will there be another billion or so dollars announced for funding DSRIP in addition to the $6.4 billion from the government, federal government?
There you go.
Thank you.
Thank you. The announcement will be coming very soon.
Maybe one more question then.
Short answer.
No. Oh.
I said the announcement will be coming very soon.
Will there be an additional?
You will, in the announcement will address that issue as well.
So we all agree that primary care is a cornerstone for achieving the end goals of DSRIP. But the interesting fact is that only 5 PPS picked up PCMH funding for PCMH to get all the primary cares PCMH level 3, 2014 level 3 certified. And second thing is, within the people who have got PCMH, they're doing more from a content perspective rather than intent perspective. So there's not a whole lot of measure coming from primary care with respect to how well they're doing the fundamentals of PCMH, which defeats the entire purpose of creating a patient-centered medical home and reduction of costs. So how can the state address that from that standpoint?
Right. Well, a fundamental element of DSRIP is that all primary care providers within a performing provider system must be to level 3 patient-centered medical home status by the end of year 3. So we see DSRIP as a major, in New York, more so than any other state, has invested in this. We have like almost, I think it's close to 2 million Medicaid members utilizing primary care from NCQA accredited patient-centered medical homes. So we're sort of on the cutting edge of this in terms of making investments, actually paying those providers more for reading those standards. So DSRIP further launches that effort, and we would love to have the entire 6.2 million people who are in the Medicaid program be able to access not just the Medicaid population, but the entire state. Why shouldn't everyone benefit from what we think is a superior form of primary care? But I know Dr. Zucker will be here later, so he might very well address this as well. But there's also the State Health Innovation Plan. And part of that is a discussion across the entire state, all payers, about what we call advanced primary care, which is this idea of taking actually a concept of patients in medical home and going even further. Integrating behavioral health services, thinking about how we can basically redesign what primary care actually means, and that whole effort is continuing to move forward. So I think that while patients in medical home NCQA accreditation is a good starting point, it can't be the sort of the end goal. The end goal has to be even more ambitious than that. And I think we have a good starting point here in New York, but there's still a good amount of work left to be done.
That concludes our panel. We're going to take a quick 5-minute break. After that, we have the City Health Commissioner, the State Health Commissioner, and so I urge you to stick around, but let's give our panel a hand. Thank you.